And I'm going to talk to you over the next 20 minutes about my early experience of using Remimazolam as a sedative agent as part of my procedural sedation technique. Now, it's interesting that actually procedural sedation came to me quite late on in my career. It wasn't until 2016 that I first developed an interest in the techniques. And that was when I was asked by a colleague if I could set up a sedation service for a fertility clinic that was moving into central Birmingham. I knew nothing about procedural sedation. So what did I do? I read about it, I visited a few other centres, I watched what people were doing, and I kind of coalesced all that kind of data and information that I got into a technique that I thought would work for us in Birmingham. And having done that, I then started to think, where else can I use procedural sedation in my clinical caseload? And I ended up starting a dental sedation service. And then over the last 2.5 years, I've really focused in on setting up and running a procedural sedation service for plastic surgery patients, which I'll talk about in a bit. So I went from, in 2016, having no experience of procedural sedation, to a point now where virtually 80% of my clinical workload is based around procedural sedation. Again, just formalities. My disclosures are that I've received financial compensation to talk to you today and also to attend the conference. That's enough about me. I want to find out about you. So I've got a few questions, and they're very straightforward, so don't worry and don't be shy. So the first question I have for you, told you it was simple. Do you use procedural sedation in your anaesthetic practice? Yes, no, or sometimes? And I'm sure in a minute I'm going to be flashed up and you're all going to tell me that you do. Sometimes, no one. So, okay. So this is not surprising. We're a self-selected audience. Good to see. The thing that's interesting there is that in the room, everyone has some experience of procedural sedation. Now, that was not me in 2016. I didn't do any. I was a cardiac anaesthetist. So if I can develop it, you guys certainly can. So next question. What drugs do you use for your procedural sedation? A, propofol plus or minus an opioid. B, a benzodiazepine plus or minus an opioid. C, propofol and a benzodiazepine plus or minus an opioid. Or D, something else. Okay. So this answer is really specialty specific, I guess. So obviously we're a bunch of anaesthetists. So as Rob's alluded to, we like to use propofol. We know a lot about propofol. We're comfortable with propofol. So I think the split was pretty much A and C, which is fine. Now, if of course I was talking to a group of endoscopists, then benzodiazepine plus or minus an opioid would be the favored technique, I'm pretty certain. So what do? I do a combination of propofol with low-dose midazolam. So my sedation technique is all based on a foundation, and that foundation is target-controlled propofol infusion, low-dose midazolam. And then depending on the level of sedation that I want to induce in my patients, I then add on to that technique. So at the deeper levels of sedation, I add in remifentanil infusion. And again, remifentanil, not Remimazolam. And I must say, this is before I found Remimazolam, so I've modified my technique subsequent to this. I thought at this point it would be useful just to give you some definitions of sedation, because it serves to focus the mind and it serves to remind us as to what we're trying to achieve when we sedate our patients. So in the UK, we use the term conscious sedation. So this is a technique where we depress the central nervous system to a point where the patient will tolerate the procedure that they're undertaking. But at the same time, you can maintain verbal contact with the patient. So it's a light level of sedation. And in my practice, probably around 15% of my patients get conscious sedation. The majority get it when they're having procedures on their face or they're having dental procedures. A small percentage of patients ask for it because they actually want to have some recollection of what's going on during the procedure, but that's rare. So what do I say to the patients? I say, what I'm aiming for is I'm aiming for a level of sedation where for the majority of the operation, you will be asleep. But if I talk to you, you will open your eyes and you will do whatever I ask you to do, and then you will go back to sleep. And what I've also realized over the years of doing this is that less is more. You can, if you give too much sedation, particularly at the beginning of the procedure, patients can become quite disinhibited and difficult to manage, particularly when the surgeon's trying to infiltrate with local anesthetic. And if I was to use a drinking analogy, I would say to the patients, and I frequently do, it's like having 2 or 3 gin and tonics, followed by a couple of bottles of Prosecco. That's my conscious sedation definition. What about deep sedation? I'll go rapidly to the drink analogy here. It's 3 or 4 large gin and tonics and 6 to 8 bottles of Prosecco, but no hangover. So deep sedation is clearly is a situation where you have a much deeper level of sedation and the patients essentially only respond to painful stimuli. The majority of my patients have this level of sedation. The issue with this, of course, is that you do run the risk of potentially running into respiratory depression and requiring airway manipulation. Not a problem for us as anaesthetists, unless you can't access the airway, of course. But it's something you need to consider, particularly when you're setting up a service, because no matter how good you are at giving the deep sedation, you sometimes do morph into general anesthesia, and you need to be able to deliver that in a safe way. So at the clinics I run, I always have an anaesthetic nurse or ODP to support me, and in fact I have the range of equipment that you would need to give a general anaesthetic, although it's very rare that we go there. So next question. When did you first become aware of Remimazolam? Now the reason I want to ask this question is that I've got to put my hand up here. I didn't become aware of Remimazolam until October last year, and here I am 9 months later talking to you, which I often reflect upon. Have we got the result? Right. Okay, so there's some very knowledgeable people in the audience, and there's 45% of people have come here to learn about Remimazolam, and I'm really pleased about that, because I was one of those 45%, as I say, when I went to a conference, which I'm just going to put up on the side in a minute, in October. Okay, so let's get to the nitty-gritty of my talk, and what I'm going to do is I'm going to talk about my experience with Remimazolam. I'm a clinician, I'm not an academic. This is not my comfort zone, standing here in front of a lectern talking to people. I'm much more comfortable hands-on giving the drug, and that's what I really want to get across to you today. So I'm going to take you through my Remimazolam journey. It started, actually it was the 19th of October 2021. I was attending an anaesthetic updates course in Birmingham. It was the first face-to-face conference that I'd been to since the pandemic started. It was great. It was lovely to meet people again, catch up. And one of the things I always do when I go to these conferences is I spend a bit of time walking around the trade stands. And just so happened that Pion were exhibiting at one of these stands, obviously promoting Remimazolam. So I went along, I had a bit of a chat with them, took some information away with me. Actually, I was giving a lecture that day, so I gave the lecture, and then I went home. And I started to think about whether Remimazolam could be a substitute for midazolam in at least some of my clinical sedation practice. So what did I do? Well, we've already heard about the pharmacology and pharmacokinetic data and the safety data of Remimazolam. So I read that. Then I thought I better read some clinical data, so I looked at the phase 3 trials, of which these are the three main ones that actually Rob alluded to in his talk very briefly at the end. The take-home message from these trials, I don't have time to go through them in detail with you now, was that yes, Remimazolam has a quick onset and offset of action, and actually in terms of its safety profile, it was at least comparable with other benzodiazepines. And again, as Rob alluded to, it appeared that actually in terms of hypotension during the procedure, that actually it was significantly lower in the Remimazolam group when compared with midazolam. And this slide just very quickly sums up the efficacy data for Remimazolam, and the take-home message there is really about the median time it takes for the patient to be adequately sedated for their sedation, for their colonoscopy, and how long it takes for them, 6 minutes, to recover. So having done a bit of reading, I thought, yeah, I'm going to give it a go. So I had to decide where I was going to use it, and that really came down to logistics. And the logistics were that it's quite difficult in the UK to get a new drug on the formulary of a hospital. But for this particular location, Cat & Co Aesthetics, the surgical clinic, plastic surgery clinic, it was very easy because I sign off all the drugs. So I managed to get some delivered within 2 days of signing the chit. I didn't actually think necessarily that Remimazolam was going to be that beneficial in this cohort of patients, actually. Turned out that it was, but I didn't think it was. But I thought it was a good opportunity to start using the drug, get a feel for the drug, understand how it interacted with, well, in this cohort of patients, I used propofol and remifentanil. So I wanted to see how it worked together. So that's why I started there. Now, the clinic's a standalone day case clinic, no overnight facility. Quite strict selection criteria because I need all these patients to go home. So fit and well, ASA 1 or 2, BMI of 30 or less. For the purpose of the Remimazolam use, no esophageal reflux, because certainly at deep levels of sedation, I would choose not to use a sedation technique for that. I'd actually give TUR and intubate the patient. I elected to use Remimazolam in patients who are having procedures for less than 1 hour, and they all needed to have minimal postoperative pain. So as we've heard, fortunately I've got it on the side, I use capnography for all my patients, so I'm pleased I ticked that box. So this was my index case. A bilateral breast augmentation, fit, young, healthy, thin patient, a good starting point. I deliberately chose to use Remimazolam in body surface surgery patients to start because I was a bit nervous, if I'm being honest, because I'd never used this drug before, and I didn't quite know how it was going to interact with all my other sedative agents. So I wanted immediate access to the airway in case I needed to get there and support that. It turns out that my concerns were not validated, but nevertheless, when you're first starting to use a new drug, you want to take it conservatively. So what I typically do with these patients is I walk them through into theatre, we get them positioned on the operating table, and normally if I'm using midazolam, I would give 1.5 to 2 milligrams of midazolam. I'd then go and set my pumps up. I'd get the surgeon to come along and scrub up, and that whole process would take about 5 to 10 minutes, by which point the midazolam's working, and then I start my infusions. But with Remimazolam, having read the data, I thought, well, I can't do that, because the patient would be sedated and there'd be nothing going on. So I connected all my pumps up, I got the surgeon scrubbed, ready to go, and then I gave the Remimazolam. What did I find? Well, I found at induction that it worked, as it says on the tin, quickly. I reduced the standard doses of propofol and remifentanil for this case because, again, I wasn't quite sure how much I'd need. And actually, I found that during the maintenance period, I really didn't have to increase the levels of propofol or remifentanil that much. Within 4 minutes, we had a situation where the patient was ready to have local anesthetic infiltration, and then we proceeded with the case. During the maintenance period, I topped up the Remimazolam every 8 to 12 minutes with 2.5 milligram doses. And actually, when I first started, I was quite religious about the timing. I had a stopwatch because I thought, well, if I don't give it at 8 minutes, the patient might suddenly wake up and, start moving about. But after about 5 or 6 cases, I got so comfortable with it that I didn't need a stopwatch. You just get a sense when you need to give the top up. The interesting thing about this was at the end of the procedure, the patient met stage 1 recovery criteria in 3 minutes. So what do I mean by stage 1 recovery? Well, that's what typically happens in a recovery room in your hospital, and that's when they're ready to go back to the ward. So 3 minutes after last skin stitch, the patient was awake. They were very happy with their result from their breast augmentation surgery. They climbed off the operating table. They sat in a wheelchair. We wheeled them around to recovery. And then 30 minutes later, the patient was ready for discharge, and in fact left 45 minutes after the final skin stitch. So that was a good starting point. And then what I did was I continued to consolidate my experience over the next few months. I think it was about case 9 when I decided that I was confident enough to start using it on patients having facial surgery. So that's when I started to do that. And then really I was just waiting for the other clinics and hospitals to get the drug. And that happened in March of this year. And that was at the fertility clinic where I work. And this actually was where I was really interested to see how Remimazolam worked. It was a bit of an anxious day, actually, when I first used it, because Rob asked if he could come along to see what I did. And, so this was my baby. I'd set this clinic up, in terms of the governance and all of that as well. And it's an odd thing having someone like Rob watching you giving sedation, because I'm used to people coming along who don't have much of an expertise in the area, and they go, oh, wow, that's really good. Right. Anyway, so I was a bit nervous about that. Again, similar selection criteria to the plastic surgery clinic, and all the patients were having transvaginal oocyte retrieval. So that's a quicker procedure, about 15 minutes, minimal post-operative pain, but the nuances of this are that patients can get pain at the time when the needle goes across the vaginal wall, and particularly so if the surgeon uses a double lumen tube, which is about 16 gauge, as opposed to 18 to 20 gauge. I should say that the surgeons at this clinic want the patient to be still. All right. They accept a bit of movement when they put the needle through the vaginal wall, but after that, they need to be still. So it's a deep level of sedation that we're going for. So 21st of March, I call it transition day because in one list, I transitioned from a technique that I've used or my colleagues have used at the clinic on 2,500 patients to a new technique, which was solely dependent on Remimazolam and alfentanil. So case 1 was there really to show Rob what we typically do. Cases 2 and 4, I substituted the midazolam for Remimazolam, but I kept the propofol infusion going, although I reduced it. And then cases 5 to 6, I got rid of the propofol, and I gave Remimazolam and alfentanil. I didn't quite get rid of the propofol. I still had a syringe in my back pocket just in case, because patients vary in how much sedation they need, as you all know. And part of that depends on anxiety levels, but it also depends on the duration of the procedure and how many follicles that the patients have. So that was a really successful day. I really enjoyed it. And moving on from that, I consolidated my experience throughout April. So what was I doing? Well, I was just refining the technique, just getting a real good feel for how it worked with this group of young patients. The staff became increasingly aware about the fact that when I came there, was using Remimazolam. The surgeons liked it. The patients really liked it too. So in terms of their intra-procedure impact, it was very similar to midazolam. They had no recollection. But what was really interesting was the wake-up profile. So they woke up very rapidly. So typically, at the end of the procedure, I'd say, can you open your eyes? And they open their eyes. And then what they'd say within 30 seconds typically would be, when am I having the procedure? You've had it. Oh, wow, I can't believe it. Yeah. So we had good feedback from that. And the recovery profile was such that I thought, actually, we don't need a recovery area for these patients. So I put a business case together, and I got that accepted by the Care Fertility Head Office. And I got my Remimazolam sedation technique signed off. Having done that in May, the training phase. Not much training to be done, if I'm being honest. What did I do? I mentored and supported my anaesthetic colleagues. And what did that mean? That meant that I'd go along to one of their sessions, I'd show them how Remimazolam worked in the patient number 1, and then I'd let them get on and use Remimazolam for the rest of the list, and I'd be there to support them. So it's got a very short learning curve. I'm now pleased to say, in June, that we've had our first list where we haven't got any recovery staff. And that was on the 2nd, I think it was. I did that list. We had 4 cases on it. And they all recovered on the procedure trolley within 1 to 2 minutes and went back to the ward. So we'll see where it goes. So I'm coming towards the end of my chat. And I've got a few observations and thoughts that I just want to let you, the audience, know about. The first thing, and I mentioned it already, is that you have a very short learning curve with this drug. It's a forgiving drug. That's what I found. You can give a little bit too much. It doesn't seem to really matter. It wears off quite quickly. One one of the things I found very early on when I started using it was that when I used it in my kind of polypharmacy technique of propofol, remiventanol, and remimazolam rather than midazolam, I found that the airway hardly ever required any support at all. And any support it did require was usually just a little bit of chin support. That was quite marked because at the deep levels of sedation that I was running for my plastic surgery patients, I'd often have to support the airway for at least periods of the procedure and occasionally put a Goodell airway in. That didn't happen with remimazolam. And I think it didn't happen because I could reduce the level of propofol I was infusing to the patients. There's no doubt it does have a rapid onset of action and early offset. And that's really important for me, certainly in my independent practice, because health economics plays a part. I need my patients to go to sleep rapidly and wake up rapidly. And if we can do that, we can get more patients through, and we can get rid of some of the expensive staff that we would otherwise require. The other impact of propofol, the propofol sparing effect, was that in my plastic surgery patients, I found that a lot of them were not getting the shakes that they seemed to get before. So for the first 5 to 10 minutes after their surgery, with my standard technique, quite a lot of young patients were shaking. They weren't cold, they were just shaking. And this was noticeably absent when I started to use remimazolam. And again, I think it was because I could really drop down on the propofol dose. So future applications of remimazolam in my practice. I'm limited by the hospitals I work in getting the drug, but we're getting over that. And I'm really excited because I've got remimazolam accepted at my local private hospital. So I'm going to start using it for endoscopy, so upper GI endoscopy and colonoscopy. But actually where I really want to see how it works is in the cath lab. I do quite a lot of work in the cath lab as it is. And there's two groups of patients I'm looking to use it in. The first is that group of patients with paroxysmal atrial fibrillation who are going to have cryoablation. And the thing about cryoablation techniques are that they're much quicker than the standard ablation techniques that the cardiologists use. The problem the cardiologists have at the moment is they use midazolam, and they often have to give quite a lot. And the patients don't recover in time to go home. So I've said to them that I'll start using remimazolam, and let's see how that goes. I'm pretty confident they'll be okay to go home if we use remimazolam, but we will see. And then the second group are a completely different cohort of patients, kind of ASA3 patients and above, and that's the TAVI patients. I'm involved in the moment in getting a TAVI program moved over to our private hospital. About 12 years ago, I was initially involved in setting up the TAVI program at my cardiac center, and back then we gave general anesthetics and full monitoring, central lines, everything. Now, of course, they mostly get midazolam. And I just want to see whether remimazolam would give some benefit to those patients too. So, thank you very much for listening. It's much appreciated, and I think we'll welcome your questions.
Thank you, David. And I hope that as clinicians you recognise the authentic voice of practice. I was keen for David to come because he's explaining to you about how he's safely transitioned a new drug into his own clinical environment. And it was particularly interesting for me to go and visit the infertility clinic because this is a commercial environment. So there's always the temptation to cut corners. I can tell you that the equipment, the staffing and the governance were outstanding. And as I've been a custodian of those at national level, that's why he was feeling anxious, but he had nothing to be anxious about. It was a very good setup. Now, we've got some questions, and I'll pick up one or two of those. So there was a question about the amnestic effects. So the question is, are the amnestic effects of remimazolam the same as midazolam? And the answer is yes and no. So all the benzodiazepines as a class cause amnesia, and that David described that in his patient narratives. If you look at the 3 phase 3 regulatory studies, which he just showed on his slide, and if you go to the company stand, they can help you find them if you want. One of them is by Rex. There is some neuropsych data about the recovery phase, and the CNS recovery after the recovery of, if you like, clear-headed thinking, unsurprisingly happens a lot faster. That with remimazolam, they're usually not significantly different from control condition at about half an hour. So that all benzodiazepines cause amnesia. Remimazolam does that too. I think the clouds lift a little earlier. So there's a question for Dr. Green about silent aspiration during deep sedation. So the question was, are there any data about silent aspiration during deep sedation?
Well, that's a good question. So if we think about our general anaesthetic patients, we have an incidence of what I think it's about 1 in 2,000 risk, something like that, of aspiration. I'm not aware of data for patients that are deeply sedated and don't have a protected airway, but I accept that, we tend to use laryngeal mask airways quite frequently, don't we, in our general anaesthetic practice? In fact, virtually all the time. So I'm thinking that the incidence will be in the same kind of region, about 1 in 2,000. Now, I've either given or my team have given now around, I think it's about 3,000 sedation cases. We've had no aspiration cases or that I'm aware of in the fertility group. We've had one aspiration in the plastic surgical group with one of my colleagues, where the patient was not asked whether they had esophageal reflux. And they indeed did have esophageal reflux, so they aspirated then. I take it that I accept that that's slightly different from microaspiration. But in my clinical practice, that's the only patient where we've had any issues so far. So I'm fairly comfortable with that level of frequency because I think it sits fairly well with the general anaesthetic.
Thank you, David. So there's another question there. The question is, did you need to give an antagonist after using Remimazolam? And there's a two-part answer to that. So the first thing is that Remimazolam is a typical benzodiazepine. That means it's reversed by flumazenol. And there is very limited experimental data underpinning that. So there's a bit of phase 1 volunteer reversal and plenty of animal data showing the reversal. And then from some of the large clinical studies, there's been the odd patient who's been slow to recovery who has been given flumazenol. Now, if we move away and go back to the 1970s and even before, when Roche were developing midazolam, they had the idea that midazolam might be useful as a general anesthetic, and I could give you a whole talk about it. It's an interesting subject, and indeed you can. You get stable anesthesia with midazolam. The trouble is the patients take forever to wake up. So then they thought, well, we could give flumazenol and wake them up, and they do wake up, but then they go back to sleep again. You get resedation. So there is no data underpinning the use of routine, non-emergent flumazenol after remimazolam. I think it's an area that might be looked at downstream. But to be honest, the patients recover very quickly anyway, particularly in the sedation space. So it's there. If you have a concern, it's something that you can use as a clinician. David, have you ever had to use flumazenol?
I've never had to use flumazenol in my sedation practice, be it with midazolam or remimazolam. You need to have it there on site, that's important, but I can't see with the doses that we're using for remimazolam sedation why you would ever need it. I mean, they really do truly wake up so rapidly when you stop giving the drug. Okay,
so there's a question here about intensive care, about is remimazolam an intensive care sedative? Now, we're in Europe. This drug is licensed for procedural sedation, not for intensive care sedation, not for induction of anesthesia, not for maintenance of anesthesia. All of those things are being explored in a worldwide development program. Remimazolam is licensed for general anesthesia in China, in Korea, but not in Europe. And in terms of intensive care sedation, there's really no data to support that. So it's not something you should be indulging in the absence of robust clinical evidence.
There's a simple question here, which is a very valid one, and that's about how much drug is in one ampule. And actually this does impact on the way that I give my sedation with remimazolam. I like to keep it down to 1 ampule. There's 20 milligrams in 1 ampule. It comes in a powder formulation. You have to dilute it up with normal saline. If you read the data sheet, you need to dilute it up to a 2.5 milligram per mil concentration. I'd recommend that you follow the data sheet. There's one thing I didn't say in my presentation, but when Prof. Sneed came, he said, "Oh, no, come on, you can put it into 20 mils. It's much easier to use." And then I got a little bit confused about what concentration of Remi I was giving. And for one patient, I started to give the drug, and they didn't really respond how I expected. They didn't really go to sleep as quickly as I thought. Oh, that's a bit odd. So I gave them a bit more, and then I remembered that he told me to change the dilution. So 2.5 milligrams per mil is what I actually use. Yeah.
Okay, so there's a question here about delirium. Now, we know that there's a lot of interest in cognitive dysfunction in patients, particularly elderly, after anesthesia and surgery, and it's a big research space. We know that benzodiazepines as a group are associated with that, and when the large clinical trials are published about induction and maintenance of anesthesia, general anesthesia, I think it's something to be looked at carefully. There's a big European multi-center study for which some abstracts were presented at this Congress, and there will be a paper hopefully later this year, and that's a good place to look. There are a small number of case reports of delirium after Remimazolam, so it's likely that as a benzodiazepine that people who are vulnerable to that may experience that, and it's certainly something to keep an eye on.
There's another question here about, is it FDA approved? Well, yes, it is. All the data, the initial data came out of the States, and there's some quite active programs over there using Remimazolam for sedation.
But in the United States, there's a time limit. You can only sedate for half an hour inside the United States product license, which does not apply in Europe. So there's a question which I'm guessing probably comes from China about ciprofol. So most of you, I'm guessing, have never heard of ciprofol. Ciprofol is kind of one of many, son of propofol, and it's been developed right up to phase 3 in China. It's one of the structural near neighbours of propofol that was evaluated in ICI's original development and didn't go anywhere, but it's found favour in China, and it presented as an oil in water emulsion, so it looks like propofol. I don't see that arriving in Europe anytime soon. So in terms of propofol versus, in terms of ciprofol versus Remimazolam, honestly no idea, but I think we'll be hearing almost certainly from China, almost certainly relatively soon, because there's a lot of research going on in that area. So we've got a couple of minutes left. So David, I've got a question for you. As an experienced clinician and somebody who's running a sedation service, not only delivered by him personally, but he also leads and employs other doctors to work in a whole range of clinics and environments, what settings and procedures do you think Remimazolam is most suitable for?
I think clearly I've talked about the fertility services. That's in the independent sector, that's a big thing, and I think it's going to be very useful there. I really want to see it brought into the private hospitals for the colonoscopy work, because there the drivers are different. Increased volume of patients means more revenue, and I really see that as being an area where we can really develop it. But I'm actually also interested in using it for more complex surgical procedures, albeit body surface, because I do a lot of work with procedural sedation for elderly patients having hernia repairs, and I get great outcomes. But I think using Remimazolam would be really interesting.
I've got one more question, which is, the question is, can Remimazolam be used by infusion? And the answer is yes, but. So all drugs are governed by their product license, and the European license for Remimazolam is for intermittent bolus injection. Now, if you're all here because you understand and you love clinical pharmacology, so you can figure out in your own heads that clearly something you can administer by bolus injections can also be delivered by infusion. You can probably work out what the infusion rates would be. So I think it's the development space. And downstream, I know, for example, Professor Streis is working on the underpinning pharmacokinetics with the lab guys in Kion towards target controlled infusion downstream as well. But these are development areas, they're not on the license. So at the moment it's licensed for use in one dilution, which is the 2.5 milligrams per mil, and it's licensed for use by bolus injections. There's lots of other interesting, exciting things coming on. So the final note, we've got the feedback form, which David is going to model. If you haven't already, could you please fill in the feedback form either electronically or on the paper, because that helps us produce a decent program for you. I'll finish by thanking David for his presentation, thanking you for joining us, thanking our sponsor for making it possible. I hope you enjoy your lunch. I hope you enjoyed the presentation. We're around for a short period, and please feel free to drop by the stand and express interest about your own practice, your own country. Thank you very much.